choices of medical residents to more clearly depict the funding outcomes by practice type, location, and retention of medical schools in Texas. The bill will help build a homegrown supply of trained physicians and help lawmakers determine which of the state's education programs are successful and help the state implement more effective policies that will help facilitate an appropriate mix of physicians. In the long run, House Bill 99 will help increase access to primary health care in underserved areas in Texas by providing accurate data to the legislature to create policies that work to attract new primary care providers and reward successful medical programs. I know we have a few people here to testify, but I'll try to answer any questions if y'all have.
Thank you, Representative Guillen. Members' questions for Representative Guillen? Hearing none, we'll reserve the right to close.
Thank you.
Chair calls a single witness that wants to speak publicly, so if you want to speak on this bill, please get registered in the queue. Chair recognizes Blair Cushing from the Texas Academy of Family Physicians. Welcome. If you, again, identify yourself, organization, and position on the bill.
Good morning. My name is Blair Cushing. I'm currently a fourth-year medical student at the University of North Texas Health Science Center in Fort Worth. I am here representing the Texas Academy of Family Physicians and speaking in favor of this bill. So within medicine, we frequently talk about the fact that we need to do things that are evidence-based, meaning that we need to follow the data and use that data in sensible ways. So essentially what this bill is asking for is that we use some of the data that frankly is already being collected, compile it, and utilize it in sensible ways to make sure that we're best serving the interest of all Texans and their healthcare needs. As was just mentioned, unfortunately in Texas, one of our greatest needs right now is that we're suffering from a tremendous shortage in terms of primary care physicians. So we need to establish our systems in ways that we can try and best meet those needs, in particular for folks who are in underserved and rural communities, which tends to be a bigger challenge in Texas than in many other states. So essentially what this bill is asking for is two different levels of data collection. One is at the level of the medical schools in terms of what happens to our graduates. So that data is very much already obtained by the medical schools. The students will go through a match process that connects them with their residency program that they will go on to immediately following graduation. Schools are more than happy to share this information. Unfortunately, at this point in time, it's just not being compiled in an effective way. So there's 4 different matches that students can participate in. The largest match is actually coming up in a couple weeks here. The schools utilize this as a recruitment tool in terms of talking about where their graduates are going on to. So again, that data is already very readily available. It just needs to be centralized and utilized in a better fashion. And by doing so, we would be able to identify which of our medical schools are sending students more largely into primary care specialties and look at the programs that they have already in place and see how we can effectively apply those at other schools that are not meeting those similar benchmarks. In terms of the post-training information or tracking what happens to our graduates once they complete their residencies, this is also data which I have found recently is very much being already collected and compiled. Having just completed my own course of interviews for residencies. Again, this is very much a recruitment tool on their part. Residencies were able to provide down to geographic areas, map versions of where their graduates are currently practicing, what they're doing, how they're practicing. For example, with primary care physicians, family practice in particular, they could tell me down to the percentage of how many of these folks are working in geriatrics or doing OB, not just where did they end up. One additional thing that we would like to see in this bill beyond the current language is to actually extend from 2 years to 5 years out how long we're tracking those graduates of the residency programs. The reasoning for that is that many physicians will not continue in the same practice setting where they initially end up post-residency. That happens for a variety of reasons. In part, there are some folks who will go on to subspecialty training and fellowships that they won't enter directly out of their residency. Some folks will seek various types of loan repayment incentives, and will go and work in a certain area for a couple of years to try and get that loan repayment money, and then move on to something else and further subspecialize. So if we really want to know what's happening to these graduates further out, we need to look at a 5-year benchmark as opposed to a 2-year benchmark. Many physicians will enter into contracts that have nice sign-on bonuses immediately out of residency, and then end up finding out it's not really the work situation that they want or that they decide they want to subspecialize. So looking only 2 years out is going to give us a flawed image of what we're actually producing. So we're very much in favor of this bill. We hope that you all would support it and also continue that minor amendment to change the reporting guideline on part of the residency programs. I'd be happy to answer any questions.
Thank you, Ms. Cushing. Members, any questions? Yes, Representative Clardy.
Thank you, Mr. Chairman. Ms. Cushing, thank you for your testimony. Very good job laying this out for us. A couple of questions. You mentioned some maps that you look at that are available within your medical school. You're at North Texas, correct?
Yes.
And these maps that kind of show you what regions are served, what opportunities are available. Who produces those?
So, in mentioning that, I was specifically referring to the residency programs. So when I was interviewing for residency programs, pretty much everywhere I went would sit down with us and trying to sell us on the program by saying, here's where our graduates end up and here's the types of things that they're doing. So if you want to be like these people, here's what we've produced. So, many of these programs, the numbers that you're talking about in terms of how many people they're producing on a yearly basis is relatively small. The largest family practice program in Texas, for example, is only 25 residents a year. So for them to track that data is not particularly burdensome. Furthermore, for physicians, the contacts that you make in residency are people who you're going to rely on for the rest of your career. So these folks are already staying in touch with the programs for other reasons. For them to obtain that data and track, what's happening to these individuals post-training is not creating some extremely large administrative burden on them. It's more just a matter of how can we centralize that data, get it to a source at the state level where we can actually, do something about that and see truly where these folks are going.
So that's prepared by some of the larger residency programs in the state?
Yeah, that's the individual residency programs are collecting that on their own graduates already.
Okay. Let me ask you a different question. Among your peers and your classmates, congratulations on your studies.
Thank you.
And the soon-to-be MD. What is is there a demand or desire within your classmates to have residency opportunities in these underserved regions of the state? I represent 3 counties in East Texas, and if there's perhaps not such a formal residency program, but those offered as smaller community hospitals or other opportunities to reach the underserved in various health clinics, etc., is there a demand for that? Do some of your classmates want to pursue that professionally?
Absolutely, and I'll tell you the one thing that I've seen and been actually very impressed by, both from my own classmates and others from other institutions that I encountered along the interview trail, is that not only are students interested in primary care, I feel in an increasing way, even over the 4 years that I've been in medical school, I've definitely seen that interest increasing, but also that there's more students who are interested in what we call full spectrum primary care, full spectrum family practice. And that training does occur in the rural communities in what we call unopposed programs. So that's, small hospitals that have family medicine as their only residency. So you're not competing with others for your procedures. You're not competing with the OBs to try and deliver babies and that types of thing. And I see that students are very much interested in that because they want to be hands-on. They want to have those types of experiences. The school I attend is osteopathic college. We have always produced larger amounts of folks going into primary care specialties than some of the other institutions in the state. And I think a large part of that is due to the mentoring, due to the focus and exposure to primary care practice that we receive. So, that's another reason why I feel like if we had this data and we could see which schools are truly producing those types of physicians, we can then go back and look at what types of programs they already have in place at those schools to try and emulate them other places. Because what I'm finding is even though all the medical students in the state of Texas do have a mandatory at least 1 month experience in family practice, that experience varies so widely. For some folks, that family practice experience is entirely based in a university hospital. And then for others, it's in a rural setting where you're really connecting with the community. You see the influence that family physician has in the community, and all of a sudden it becomes a much more attractive type of practice than it would have been otherwise.
Okay. And if I said MD, I meant DO. But on the if you couple what you've mentioned with the opportunities for debt forgiveness for serving in underutilized areas, that would be an additional incentive for medical students to pursue these underserved regions of the state. Wouldn't you agree?
Absolutely. Personally, although it's a couple years out still at minimum, I think about that all the time. I think about, how can I best maximize my ability to try and utilize those types of programs to do what I want to do, because I recognize going into family practice, and in particular, my desire is to potentially have solo practice. I want to work on the border, and I'm up against all these different types of challenges. To know that those programs exist and that there's other ways to kind of incentivize me or cushion the burden, I guess, of being able to practice those environments is very much a big deal.
Very good. Thank you very much.
Thank you.
Representative Clardy. Chair Crown over.
I just want to welcome you, and it's wonderful to think about what you are desiring to do. I grew up in a little tiny town, and Dr. Bill was practically a part of our family. So, yeah, you have a wonderful career ahead of you, and I wish we could clone a bunch more of you. And the Health Science Center in Fort Worth is doing a great job of that. So we're so glad that you could take the time and be here today. Thank you.
And in terms of the cloning comment, I will say you all absolutely do have the opportunity to do that. And again, by investing in these types of programs, I think, I truly do believe that, it is the exposure. I didn't come into medical school saying I wanted to do primary care, not at all. Even on my first primary care rotation, I actively fought my preceptor and said, I'm not going to do this. And she was very pleased about 8 months later when I stood up at the TAFP conference and did, I'm going to do family practice because it was the right fit. But again, it's about that exposure. It's about the mentorship. It's about being in an environment where family practice and any type of primary care is very much encouraged rather than discouraged, because there are a lot of discouraging statements that will be made to those students along the way. So the more we can do to support them and make this an easier choice for them, the more likely we are to get the graduates we want going into those fields.
So what made that transition for you?
Well, my background was in social services. So I very much care about the patient relationship and being able to interact with people. And family practice was actually the first rotation that I did in my third year. And so everything else I was kind of comparing to family medicine after that. And every other rotation I went on, I didn't like the way that those physicians interacted with patients. And by large part, it was because of the restraints that are put on them by the way that they have to practice. But I very much realized, I want to spend time with people. I want to have those relationships. I'm not willing to walk away from that manner of treating people. And then also I wasn't willing to cut out any population. I wanted to deal with the kids, I want to deal with pregnant women, I want to deal with geriatrics, and there's no part of the lifespan that I don't want to deal with. So for me, those were my decision-making factors.
Well, great. Good to hear your story. Thank you for coming today.
Members, other questions? Ms. Cushing, I likewise congratulate you on the near completion of your career. I know it's a very anxious time coming up on March 14th.
Rank list is due today.
What's that?
The rank list is due today.
Yeah. So I will say, members, that this is probably one of the most anxiety-provoking times in your whole medical school career, because everything's on the line at this point. And it, as Ms. Cushing has said, it truly kind of defines where you end up in your medical career, your medical practice and stuff. So congratulations. You have a great career ahead of you, and appreciate you very much participating in this process.
Thank you all very much.
Thank you. Appreciate it. Members, there is no other public testimony. Speaking for the bill, there are several people who have provided written testimony. Justin Yancey from the Texas Business Leadership Council, Marshall Kinderdine from Texas Academy of Family Physicians, Nelson Salinas from Texas Association of Business, Jennifer Banda from Texas Hospital Association, and Joel Ballou from the Texas Health Resources. Is there anybody else that wants to speak on, for, or against House Bill 99? Hearing none, we now recognize Representative Guillen to close on his bill.
Thank you, Mr. Chairman. The amendment that she talked about, we have that ready. We just didn't make the 48-hour committee deadline, so y'all should be receiving that soon. And if there's no further questions, I just ask for your favorable consideration, and I close.
Terrific. Thank you, Mr. Guillen. Any questions for Mr. Guillen? Members, hearing none, there'll be no more questions, and we will leave this bill pending if there is no objection. Hearing